Thanks so much for joining, Anne-Marie. It's great to have a chance to catch up.
Great. And Maeve, you're doing some research on breast cancer.
Yeah, that's correct. Yeah, I'm doing a 2-year clinical research fellowship under the supervision of Roisin Connolly, one of the consultants in CUH. And she's also the chair in UCC for cancer research.
Okay. Do you want to tell me a bit about breast cancer?
Yeah, sure. So breast cancer is the most commonly diagnosed cancer in females. And recent data would say maybe 2.3 million new cases are diagnosed globally every year. So it really has quite an impact. Like any cancer, breast cancer develops when the cells in the breast start to grow abnormally. And they then may form kind of lumps, or what we call tumours. And despite, there have been a lot of improvements in breast cancer, but research is really important because it's still the second leading cause of deaths for female cancer-related deaths. But we have seen great improvements. In Ireland, maybe 1 in 9 women will be affected at some point during their lifetime. So it really does affect a large number of people. But the survival rates are improving, and that's down to our screening programs. There's more awareness now among the community, and also we have a lot of new treatments that have come through thanks to breakthroughs in research. So.
And is there just one type of breast cancer, or does breast cancer get subdivided?
Yeah, so that's a great question. Breast cancer, it's not one size fits all. It's actually made up of many different types. Typically, for the purposes of treating breast cancer, we divide it into 3 types. So there's hormone-positive breast cancer. So these cancers grow in response to estrogen and progesterone hormones. There's a type of cancer called HER2-positive breast cancer. And this is cancer where the cells have too much of a protein called HER2 on the surface. And this HER2 protein, it's like a switch that tells the cells to keep growing and dividing, and then they can grow a little bit out of control. But we have new treatments for HER2-positive breast cancer that have really improved outcomes. And then the third type is triple-negative breast cancer. And this is called triple-negative because it doesn't have this extra estrogen, progesterone, or HER2. And so this type of breast cancer is probably about 15 to 20% of breast cancers. And usually we treat it with chemotherapy. But again, there's been recent breakthroughs and immunotherapy and new treatments for it as well.
And I'm particularly interested in HER2 positive because that's what I was diagnosed with, I suppose. And it's one of those terms, I suppose, once they told me, I wanted to know, is this a good type of breast cancer? Is this a bad type? Is there a hierarchy, or not a hierarchy is the wrong word, but, are your likelihood of treatment being successful, does that increase with the type of cancer you have, or?
Yeah, so I would say that really the outcome depends a lot on the stage at which it's diagnosed. So the earlier the cancer is diagnosed, usually the sooner the treatment can get started, and in general, the better the outcome. HER2 positive breast cancer, traditionally, when we didn't understand this mechanism of targeting the HER2 and we didn't have good drugs, the outcomes weren't as good. But now there's been such a great understanding of how targeting this HER2 protein and all of these new drugs have been developed, that there have been really exciting advances. And so people are doing really well with this type of breast cancer.
And with HER2 positive, you mentioned that it's like a protein that acts like a switch. Is that right? So has that always been, did I always have that? Like, did I always have these cells that it was just a matter of time before they switched on, or?
So I suppose it's something that develops over time when it loses control over the signaling pathway and the mechanism, and then when it goes out of control, that's when these cancer cells develop. Yeah.
And so I had stage 3 HER2 positive, stage 3, grade 3. Yes. And does that mean that at some point, like it was stage 0, it went through stage 1, it went to stage 2, went to stage 3, or does the grade mean that it was just started at stage 3. Do you know what I mean?
Yes. So okay. So as you say, there's different stages. So we usually stage cancer stage 1 to stage 4, and the stage is based on several things: the size of the tumor, the number of the lymph nodes involved, and then if the cancer has spread to other areas. So in general, stage 1 would be smaller cancers that are localized just to the breast. In stage 2, the cancer cells may have now spread to the glands under the arm. Stage 3, there's more glands under the arm involved. And then in stage 4, the cancer has escaped out of the breast and the local glands and has gone to other parts of the body, which could be the lung, the liver, the bone, most commonly, sometimes the brain. The grading then is how the cells look under the microscope. Do they look like normal? Do they look close to how normal breast cancer cells look? Or have they started to kind of morph and look very abnormal? So grading is 1 to 3, and in general, again, grade 1 would grow a little slowly and grade 3 would grow more quickly. So it sounds like at the time when you were diagnosed, it was picked up that you had stage 3. So at this point, they would have told you there were some glands under the arm as well as a tumour in the breast, but there was no sign that the cancer had gone anywhere else. So that's a good situation to be in. You know, that's a curable situation, and that would be the goal of the treatment. So it's likely that, you know, there probably was a small tumour there and it was getting bigger, and then at the time that it was picked up, it was a little bit bigger and had gone under the arm.
Okay, so so there, I suppose the message then being the earlier that you get it, the more likely that the treatment would work. And where do you focus your research? Is your research looking at a particular stage of HER2?
So women like you who would have what we call early HER2 positive breast cancer, kind of stage 2 to stage 3. And the general treatment approach for this type of cancer, which you may have had yourself, is you get a combination of chemotherapy and these HER2 targeting drugs together. Is that what?
Yeah, so I had TCHP, and I had is it neoadjuvant,
Exactly.
pronounce it? Yeah,
Yes.
yeah. So I had chemotherapy first, and then my surgery, and then the radiotherapy.
Yes, so that would be very standard for HER2 positive breast cancer. So we give the chemotherapy with these other HER2 drugs. So you got 4 drugs, the T, C, H, and P, and we give them first. And this allows, you know, the treatment to start working on the cancer, on the lump. You might have noticed yourself that the lump had started, you could feel it shrinking.
Yeah, it was very bizarre. You could, and I was saying that to my oncologist, I could actually feel like it was work, like that the cells were kind of in a bit of a battle. And he was very reassuring that this happens and that some people don't, and that doesn't mean it's not working either, but that's what I was feeling, is that kind of, I suppose, battle of cells versus medicine within me.
Yes. So the idea is that, you know, by the time of the surgery, that hopefully the treatment will have shrunk the tumour a little bit to help the surgeons, and also in case there were any microscopic cells that had escaped, that we're getting all of this treatment in nice and early to give you the best possible chance. And that word neoadjuvant, as you said, means upfront, before the time of surgery.
Okay.
So as you say, you got 4 drugs. This is, you know, this has really been shown to improve the outcomes, but it's quite likely that there are some patients who may not need all 4 drugs. Because the treatment is, did you find the treatment tough?
Oh, it was awful.
Yeah.
Yeah. I feel like I should put a positive spin on it, but no, it was awful.
So there are a lot of side effects.
Yeah.
Everything. So the goal of my research is to try and figure out, are there certain biomarkers, which, like a sign or a clue in your blood or in your tumour, that can help us to decide, well, do you actually need all 4 of those drugs? Or maybe you might be doing just as well with just 1 or 2 of the targeted drugs. Maybe you don't need the chemotherapy. Maybe we're doing overkill.
Yes.
So we don't want to treat all patients with this kind of blanket approach. And we want to kind of tailor the treatment more towards the individual person.
And how do you do that in research? Like, how do you?
Yeah, so I've been lucky enough to collaborate with Johns Hopkins on a trial that Roisin Connolly led when she was over in the States. So this was a multi-centre study. It took place in a number of different cancer centres in America. And the goal was to try and use PET scanning. So PET scanning wouldn't be traditionally what we would use in breast cancer. You probably had an ultrasound or a mammogram.
Do you get? Is that the one you get a thing to drink beforehand?
You get, they inject. It's like a sugar.
Yeah.
And it travels to the places where the cells are more active.
Yes. No, I did have it. Yeah.
So it gets picked up by cancer cells, usually because they're growing more quickly. So there's CT scans and then there's PET scan. That's a little bit more
I had a PET
scan. Yeah. So the study was looking at using PET scanning in women that had early stage HER2 positive breast cancer, and they would have a scan at the start of their treatment. And then they would have a scan after 2 weeks of just the HNP drug, just the HER2 targeting drug, so no chemotherapy. And the idea was that if you were responding to the treatment, that bright spot on the PET scan should be less bright on your repeat one at the 2 week mark. Does that make sense?
So people signed up to okay, and was there any difficulty in getting people to sign up? We're going to give you less than we would normally give and see how that goes.
Yes, exactly. Well, that's a great point. So there was an option, obviously, if it looked like it wasn't working or the treatment they weren't responding, then the chemotherapy was added. And so that's the idea going forward, that treatment could be adapted. So we could use the PET scan as a tool early on in someone's treatment plan. And then based on that, we could either, intensify their treatment, or we could say, actually, you're doing really well on these two drugs, so we'll continue.
And is there, have you found that there are certain markers, that there's a certain cohort of people with a certain...
So there was a certain cohort of people that had responded on the PET scan at the second time, and those people then were found to have done better at the time of surgery. The cancer had responded. So my research then was building on that and looking at the survival outcomes. So looking at this cohort, and did the people that had a response on the scan, did they end up having a better survival? And interestingly, we found that was the case. It looked like there was a connection.
So the less drugs that people had at the start, the greater their survival? Was that?
More so, I suppose, the fact that people were getting less drugs and were able to have equally good survival than what we might see in the traditional 4-drug.
Okay, so it wasn't that it equated to greater amount of survival, but it was equal.
Yes, and I suppose the whole concept was using the PET scan to see, could this guide the treatment. Yeah.
So I had a PET scan because it was a question of whether there was cancer had travelled to my neck. Okay. I think that was why I had the PET scan. So it's not generally part of
Because it's not generally part of the workup, yes. So that explains why, you had the PET scan.
Okay. So the treatment that I had was TCHP. Could you tell us a bit about that?
Yeah, sure. So the treatment that you got would be the standard treatment that we give for people with, an early stage HER2 positive breast cancer. So it's 4 drugs. The T and the C are 2 chemotherapy drugs, docetaxel and carboplatin. And then the H and the P are 2 HER2 targeted drugs. So you're getting a combination of both chemotherapy and then more specific targeted treatment that's acting on that HER2 protein and blocking it from causing the cells to grow, out of control.
Okay. And you were mentioning with your research that it seems that the PET scan is quite important in the process. Is that use that as kind of to determine whether...
Yes, so the idea of the PET scan is to use it as a tool, really. If we can use it as a tool early on in someone's treatment to help us identify, are they responding to the treatment that we're giving or not? then that means we can adapt the treatment. So if it looks like on your second PET scan that the treatment isn't working as well as we may have hoped, we have the opportunity then to add in further drugs, for example, chemotherapy. Whereas if it looked like on the PET scan that the treatment was working very well, perhaps you could continue then on 1 or 2 drugs. Does that make sense?
It does. It's like you're live tracking.
Exactly.
Yeah. So it's not kind of, let's go put you through the chemotherapy and we'll see how you are at the end. You're actually
You're monitoring it
yeah.
while you're on the treatment and getting an idea of whether or not the treatment is working. And actually they use this already in lymphoma. It's a standard tool that they use in lymphoma.
And is there a reason it's not currently used in breast cancer, or?
Well, we're investigating it, and if it looks like these trials are all promising and confirm the results, then hopefully it may be brought in and it may be available to patients.
Yeah, because that could be really reassuring. And even if you are finding the treatment difficult, then if you have your PET scan and you know that this is, you've got a picture, or if you need to escalate your treatment, then you know that, okay, well, we know this isn't working, so now we know the next step.
Yes, that's the whole idea.
Yeah. And it'd be easier to face, I would think, as a patient as well, of kind of going that, okay, we've tried this and this hasn't worked, so now we know that we need this next step.
Yes, exactly. So that's the ultimate goal. Yeah.
And is there anything that, like, we as the public can do to help research?
Yeah, so I mean, my fellowship was funded by Breakthrough Cancer Research, so this gave me time to take, 2 years to work on breast cancer. So just really appreciative for all the funding that the public does for cancer research, because it's very important, and we wouldn't be able to, make all of these discoveries and progress without the support of the public and organisations like Breakthrough.
And I think it's really, I want to say thank you as well, because it's really reassuring to know that this kind of research is happening and that it isn't just, we have a treatment for that, let's leave that. It's kind of looking at modifying it and making it the best that it can be, so the treatment experience and the outcomes are equally good, which is really encouraging for somebody who hasn't been through it. So thank you. So is this, how does the kind of trajectory go of, so you have this information and presumably these body of people have been part of a previous trial, which is why that they were, and now what happens with that information?
Yeah, so the next step, we need to look at this in a larger number of women, and we need to look at it across all of the different standard regimens. So as you were saying, this was just a 2-drug regimen. So we'll look at it across all of the different treatments we usually give for HER2 positive breast cancer in a larger number of people and see, does it still look like it's a good indicator?
And what's a larger number? What kind of scale does it?
I suppose if we could get, 100, so there was 80 or so patients in this trial. So if we could get, more like in the hundreds. Yeah. And so there is another trial that's been running now and accruing, and it's based on the results from this study. So as you say, you kind of move forward once one study's been done to try and bring it to the next stage.
And so people in Ireland now who are being diagnosed with HER2 positive cancer, is it an option for them, or is it there a particular age group you're looking for, or is it anybody within?
So at the moment this isn't open in Ireland, but we'll be using the information that we get from these larger international studies, and the hope is that at some point in time that this will, if this is confirmed, that this may become part of a new standard of care and change the way we treat HER2 positive breast cancer. Yeah.
And is there a set number of years, what would prohibit it coming to Ireland? Would there be a set, it has to be, is there something you're looking for it to reach before it would be brought to Ireland, or is it just where the funding is? Or?
It's just at the moment the funding is in the States.
Okay.
Yeah.
Okay, so there wouldn't be anything against bringing it to Ireland, it's just that it's not.
No, and we really need to, Ireland has so many great clinicians, and a lot of them have had experience working in large centres abroad and have brought that knowledge back to Ireland. So we really need to push for investment in our clinical trials infrastructure and try and get more patients involved in clinical trials, because trials bring the advances and they allow patients access to new treatments as well.
And is there a take-up of trials in Ireland? Like, would Ireland be known as being generally good at taking up trials, or, you know?
So I think we have a really good reputation in terms of our standards, and all of our trainees and our consultants, you know, have excellent qualifications. At the moment, the goal of the National Cancer Strategy is to have about 6% of patients enrolled on a clinical trial, and we're probably at around 2 to 3%. So there's definitely scope to improve this.
Is there, like, maybe it's because I didn't fit any box as such, but I didn't get any information about a trial being an option, or, you know, is that up to me to ask? Should patients be a bit more proactive in asking? Or
I think it's a two-way street, really. You know, we need to promote awareness among clinicians as well, that we take the time in the clinic to go through various options. But it's really good as well if the patients can be informed, and maybe we need to have more information out there. You know, Cancer Trials Ireland does have a very good website. It might have been the case that at your time that you were diagnosed, there wasn't a suitable trial in HER2 positive breast cancer.
Yeah. And I think, well, certainly from my perspective anyway, as soon as I found I was diagnosed, I kind of just handed myself over to the oncologist, just tell me what needs to happen, and, you know, you lay the path that you know, and I will follow, kind of, you know. I think that's certainly my approach anyway. I suppose everybody approaches it differently. And overall in the research, kind of, where are you at, and how do you feel?
Yeah, so coming to the end of the research now, I should mention as well that we have plans to open another clinical trial for patients with triple negative breast cancer. Okay. Yeah, through CUH. And we're hoping to look for these biomarkers that I was talking about, but in the triple negative breast cancer cohort. And so we'll be taking tumour and blood samples from patients when they're diagnosed, and then throughout their treatment and at the time of surgery, and working with our colleagues in UCC and APC microbiome. Professor Mark Tagney has a lot of experience in the microbiome. So the bacterial composition of the breast, now there's some evidence to say that that could influence how you respond to treatment. So we're going to look at this.
I don't even know what to tell me that. What does that mean?
I know, yeah. So they took breast tumour samples, and they could see that in the breast tumour there was different bacteria there than what there was in normal healthy breast tissue. Okay. So it's something they want to explore further.
And do we know how that currently we don't know, I suppose, or do we know how that gets there, or how that develops?
We want to learn more about it, really, and to see can it provide a marker as to how well the treatment is.
And would that be specific for the negative?
We're investigating it in triple negative breast cancer, just to narrow the focus of the research. Yeah.
Okay.
Yeah.
And with triple negative breast cancer, is there? Again, there's a set path, I'm presuming, of a set chemotherapy. It's not TCHP, but it's something else. Exactly. And would that that research that you'd be looking at as to making that more targeted again?
Exactly, to tailor that as well, because as well, the new evidence for triple negative breast cancer is a cocktail of, 4 or 5 chemotherapy drugs and an immunotherapy drug. So it is a lot of treatment. So exactly, it's the same idea. Trying to overall make treatment more individualised and more personalised to the patient.
Okay. Yeah. And I suppose my brain is kind of whirring about the idea of having, what I liked about my treatment approach is I felt it was belt and braces. I felt they were throwing the bus at it. Yes. And I felt a confidence in that, I suppose, of feeling that, okay, this is absolutely awful to go through, but it is everything that they can give me that can defeat this cancer. That was kind of my approach to it. And do you find there's a hesitancy from people to be like, I will take less than what's currently recommended,
Yeah, I suppose ultimately, these things have to be proven in clinical trials, for us to introduce them as a standard practice. So obviously we wouldn't be advising anything that looked like it was inferior. But if we could say that, well, it's actually the same and there's less side effects associated with it, because chemotherapy has short-term and long-term side effects.
Yeah. Oh, it's an awful thing to go through. And if it could be targeted in some way, at least you felt then that everything you were getting was being directed towards that cancer.
Yeah.
Wow. Amazing.
Yeah. Did you have anything else from your own experience that you wanted to share, or anything that you noticed going through the treatment?
Yeah, that's a good question. I don't know that there's anything specific. I suppose that when you were mentioning earlier about early stages of cancer, and you said stage 2 and 3, in my mind, early was always 0 or 2. Yes. So would people with 0 or 2 stage HER2 positive breast cancer, would they be going through the same chemotherapy as people in stage 2, 3?
Yeah, so 2 and 3 would generally, so say if the tumour is over 2 centimetres, or if there's lymph nodes under the arm, they would usually get the treatment that you got. If you have a very small HER2 positive breast cancer, yes, you're right. Usually you go for the surgery first and then you get the chemotherapy and the HER2 therapy after, and it's only two drugs.
Okay.
Yes. Yeah.
Oh, so the TCHP is only for stages 2 and 3?
Usually, yes.
Yeah. And so stage 4 then?
So stage 4 then, the goal is to try and control the cancer, and we have a lot of people living for a long time with stage 4 breast cancer, and usually it's a combination of drug treatment, so chemotherapies and HER2 therapy.
But you wouldn't be going TCHP for a long time, because that'd be too much.
Exactly, yeah. So you would do a number of rounds and then you would maybe go on a maintenance treatment. Yeah, you couldn't obviously take those 4 drugs indefinitely. Yeah.
Okay.
Yeah.
Great. Is there anything you want to add about your research, or?
I don't think so. I think we've covered it all. Was there anything that wasn't clear?
No, I think I think I've got a good gauge of it. It's a lot like, I think the main 2 things that I was thinking before we sat down were the first one about taking less drugs, but now you've explained that very clearly. I feel if it was presented to me, I would feel a lot more confident in making that choice. And then the second thing, I suppose, is the possibility of reoccurrence. But that's what your research in particular was looking at, is that?
Yes, and all of the treatment that we're giving, in someone like you, is to prevent a reoccurrence. Your cancer has been removed by the surgery. Yeah.
We're nowhere near finding out what kicks these proteins.
I suppose it's still it's still all being investigated.
That's the golden nugget.
Yes.
Somewhere else. Yeah. But the step that you're working on is making the treatment as
targeted and more precise and more tailored. Yeah. And I suppose the main message really is that there are so many different types of breast cancer. They're all treated in different ways. And so someone's individual plan, might be different from someone else's, and that's a good thing.
Yeah, it is. I suppose it's not just kind of whacking every nail with a sledgehammer and hoping for the best. Yeah, that's great. That's very clear. Thank you very much.
Okay, thanks a million.